Hello, everybody. My name is Niki Karavitaki, and I am an associate clinical professor at the University of Birmingham and a consultant endocrinologist at the Queen Elizabeth Hospital, Birmingham, in the UK. It is a great pleasure for me to join this wonderful meeting and be able to contribute with sessions which I hope you find useful and enjoyable. So in this session, I will cover the topic of pituitary apoplexy. And this is the outline of my presentation. We will discuss what is apoplexy, how common is it, what are the factors which are associated with it, how is it caused, when to suspect it, and what is the differential diagnosis. Then we will go through the diagnostic and management approach, and we will finish with some conclusions. So what is pituitary apoplexy? This is a clinical syndrome which is attributed to acute hemorrhage and or infarction of the pituitary gland. And I emphasize that it is a clinical syndrome. We have to have the clinical picture to put this diagnosis. It is usually due to hemorrhage within a pituitary adenoma. And how common is it? Based on published data, its prevalence is around 6 cases per 100,000 people, and its incidence is around 2 cases per million per year. And it seems that the pituitary apoplexy presents in about 2 to 12% patients with pituitary adenoma. And in the majority of them, as we can see, the adenoma was not previously known. In terms of tumor subtype, the majority are non-functioning pituitary adenomas, followed by prolactinomas and somatotroph adenomas. It usually presents in the 5th to 6th decade of life, and we see a male preponderance. Now, what are the factors which are associated with pituitary apoplexy? Here is a list of what has been reported. So some of them are major surgery or invasive procedures, or drugs like GnRH analogs, or drugs that we use for endocrine dynamic testing, or arterial hypertension, or use of anticoagulant medication, diabetes mellitus, closed head trauma, etc., etc. However, factors that may be associated with apoplexy have been identified in up to 40% of the cases. And for some of them, there is still controversy as to whether they do relate with a pituitary apoplexy, like hypertension or diabetes mellitus or dopamine agonist treatment. For these factors, an etiological relationship has not been necessarily proven, but the time course of the events support the concept that they may predispose to pituitary apoplexy. And other factors that may contribute are fluctuations in the blood pressure and hypotension, vasospasm, and microemboli. Now, a question that we may come across our clinical practice is when we have a patient with a known pituitary adenoma, and this patient needs to start anticoagulation treatment. The question is how safe is to start anticoagulation treatment. And there is no evidence-based guidance to give us a risk, specific risk of developing pituitary apoplexy in these cases. And of course, as you can imagine, our advice will be based on the risk and benefit ratio for not commencing anticoagulation treatment. Now, how is it caused? Proposed mechanisms include outgrowth of the supply of the blood supply in the tumor, compression of the pituitary vessels at the diaphragmatic notch, poor intratumoral vascularity, or inherent fragility of the blood vessels of the tumor. And this lead to hemorrhage, necrosis, swelling, increased intracellular pressure, and compression of the surrounding structures, and then the typical clinical manifestations. Now, when to suspect this condition? We have a constellation of manifestations which can give us a more robust idea that we are dealing with pituitary apoplexy. And these include acute severe headache, which is quite typical. The patient describes it in a very vivid way, combined or not with nausea and vomiting. We have neuro-ophthalmic signs, which could be issues with the visual acuity and visual fields or ocular pulses. We may also have fever, neck stiffness, photophobia, reduced consciousness. And if these symptoms and signs present in a patient who already has a known pituitary tumor, all these should enhance the index of suspicion that we are dealing with pituitary apoplexy. In terms of frequency of the manifestations, this is a table we had produced in a paper we had published in the European Journal of Endocrinology a few years ago. And as you can see, headache, nausea, vomiting, and visual impairment dominate. We can have ocular nerve pulses, mainly the third one. This is the most frequent. However, we can also have altered mental state or coma, or manifestations of anterior hypopituitarism, which, as you can imagine, should have been there for a while. We can also have electrolyte disturbances like hyponatremia or diabetes insipidus, and indeed, diabetes insipidus can be seen in a pituitary adenoma when it is apoplectic at presentation, and other much more rare manifestations with sudden death, thankfully being an exceptional scenario. Now, what are the major differential diagnoses to think of? We have to consider of subarachnoid hemorrhage related with a ruptured intracranial aneurysm or venous malformation. We have to think of meningitis, of cavernous sinus thrombosis, and of brainstem infarction. And here, the value of the non-enhanced CT, the lumbar puncture, the CT angiography, the culture of the CSF, or the use of appropriate imaging will help us put the differential diagnosis to the correct direction. Now, once we have the suspicion of the pituitary apoplexy, we have to remember that this is an emergency situation. So ABC, airways, breathing, circulation if the patient is unstable. We have to take supportive measures to make sure that our patient is hemodynamically stable. We offer a stress dose of hydrocortisone. We offer this immediately after we have taken the blood test for cortisol measurement. And the advice is that we offer a stress dose if high index of suspicion of pituitary apoplexy. From my side, I prefer to have even a low index of suspicion so that I offer hydrocortisone so that we are in the safe side. We obviously have to assess and manage the fluid and electrolyte balance. We need to send urgent biochemical and hormonal bloods. We need to do visual assessment, bedside or formal, and of course request the urgent imaging, the CT of the brain, as we said, and then MRI. And of course, as you can imagine, all these run in parallel. Now, a couple of points on the imaging findings. In the hyperacute stage, which is within the first 6 hours, the CT shows a hyperdense lesion which has minimal contrast enhancement. And of course, such imaging features, hyperdense lesions, can be seen in aneurysms, in meningiomas, in Rathke's, in craniopharyngiomas, germinomas, lymphomas, some example. But it is the clinical picture of the patient that will make us think we are dealing with pituitary apoplexy. Within the first few hours, we have to remember that the MRI shows an ISO or slightly hypointense lesion, and therefore it may not be helpful. It will not be helpful for establishing the diagnosis of pituitary apoplexy based on imaging findings. And as the hours pass, so we have the acute stage, which is after the first 6 hours up to around 7 days. What we see on the CT is that there is a reduction in the density, and this is because of the evolution of the blood degradation products. And this is where the MRI has a major role, where we can see hyper or isointense signal. This is on T1, whereas in T2, we have hypointense images. So coming back now to the patient, we have confirmation of the apoplexy based on the clinical picture and based on imaging findings. So the patient has to be put under multidisciplinary care with an endocrinologist, surgeon, pituitary surgeon, neuro-ophthalmologist. We continue with stress dose of steroids. We replace the TSH deficiency after we have obviously obviously given hydrocortisone, and we monitor and manage the fluid and electrolyte balance. At the same time, we assess for severe impairment of the visual acuity or visual fields, or for progressive deterioration of them, or for altered consciousness. And now the major question which still asks for an answer: what is the best management strategy for these patients? Is it surgery or is it observation? Generally, the guidelines suggest that surgery should be considered when we have severe impairment or deterioration of the visual acuity or visual fields. I still ask myself, what is the definition of severe impairment? And I think I still don't have an answer to that. And of course, we will consider surgery if there is deterioration in the level of consciousness. We will consider observation on the other side if there is no severe impairment. And again, I still have the question, what is no severe impairment, or there is deterioration of the visual acuity or visual fields. We will consider this option if we don't have deterioration of the level of consciousness, and of course, in frail patients who would not be good candidates for an operation. And now let's look at the outcomes of each option. And let's start with the visual outcomes. So these are data from a published series looking at visual field defects, visual acuity, and oculomotor nerve palsies. And I will focus on the complete resolution. And we see that visual field defects, there is complete resolution in 31 to 57%, visual acuity in 44 to 57%, and oculomotor nerve palsies in 63 to 83%. We have to remember that there are selection biases here. Selected patients went for surgery. Now, another point to keep in mind is that the improvement in vision occurs immediately after surgery and does continue for variable intervals. How about conservative management in terms of visual outcomes? And again, we look at complete resolution in 50 to 80% of those with visual field defects. We have complete resolution of visual acuity problems in 45 to 75% of the patients, and a complete resolution of oculomotor nerve palsies in 75 to 100%. So having a quick look at these numbers, we get the feeling that conservative management has better outcomes. However, we have to remember that there is selection bias, and patients who underwent conservative management, practically they had less severe visual deterioration, and therefore this made them candidates for conservative management. So they started from a better baseline, and probably this is why we see these better outcomes. And just to emphasize that for the oculomotor palsies, if we go for surgery, the timing of surgery does not influence outcome, but the recovery, as probably expected, is shorter if we offer early surgery. Now, are we going to advocate immediate or delayed surgery? And this is a paper published more than 20 years ago from Oxford, showing that immediate surgery, and this was within 8 days of the event, had better improvement in the visual acuity compared with delayed surgery, which was offered between 9 and 35 days. But further papers followed on that, and they did not really agree with this concept. The general conclusion from these papers was that probably there is a difference between treatments. However, again, we have selection biases because patients with with less severe visual dysfunction would most likely offer conservative management, and therefore their outcomes are affected by that. Now, in a small series, though, it has been suggested that if we have severe deterioration, visual deterioration, and we delay the surgery, this can have a negative impact on the visual outcome. So we keep this in mind. So with this data in our mind, we have to make a suggestion. We have to make a recommendation. What are the points that will make us opt surgery or observation? Now, an interesting point is that if there is a single large hypodense area within the tumor, as opposed to many small hypodense ones, this relates with tumor resolution. And this may make us think that probably we could continue with observation. However, we have to keep in mind the tolerance of the optic nerve system to ischemia, which is low. So when we are dealing with a severe impairment and we have a long interval until treatment, these two factors are predictors of poor recovery. So we keep this in mind when we make our management decision. In terms of endocrine outcome, following surgery, some degree of hypopituitarism has been reported between 45 to 87% of the cases, and these are the individual deficits, which are quite substantial, as we can see, and in terms of permanent diabetes insipidus in 2 to 11% of the patients. There is a possibility of recovery of the pituitary function after surgery, whereas if we go for conservative management, again, the deficits are quite high, individual deficits, really high numbers, and recovery of the pituitary function is very unlikely. So it seems that overall, the endocrine prognosis, the hormonal deficits, is not optimal, no matter the choice of management. And this makes us think that the endocrine outcome is probably not a primary criterion for decision making. Further outcome, tumor control. What does surgery do? This is a paper we had published more than 10 years ago now, in which we looked at patients with acute pituitary apoplexy, and they had a non-functioning pituitary adenoma. And these patients underwent surgery, and half of them had partial removal of their tumor. And we found that the cumulative probability of tumor regrowth was 13% at 5 years, and all these patients have had partial removal. And of course, this number is much lower than what we would expect in terms of tumor regrowth in a non-apoplectic, non-functioning pituitary adenoma, which underwent partial removal. However, this number still shows that even after apoplexy, there is a potential of tumor regrowth. And if we look at conservative management, as probably expected, we have significant tumor shrinkage as time passes in more than 50% of the cases. And it has also been reported that the biochemical remission, spontaneous biochemical remission, can be seen after pituitary apoplexy for patients with acromegaly or Cushing's or prolactinomas. However, in a large case series, near 90% of the functioning tumors remained active after apoplexy, and the majority of them required surgery. In terms of tumor growth after conservative management, this has been reported between 0 to 22% of the cases during variable monitoring periods. So in terms of tumor, it is very difficult to compare the outcomes following surgery or observation. It is really challenging, and it is difficult to provide a robust recommendation. So this is the UK algorithm. This is the algorithm we follow in the United Kingdom, and it relies on the Society for Endocrinology guidelines. So if we suspect pituitary apoplexy, we definitely need immediate supportive measures to ensure hemodynamic stability, make sure fluid and electrolyte balance are looked after appropriately, consider hydrocortisone replacement, urgent bloods, biochemical and endocrine bloods, urgent imaging, liaise with the regional endocrine and neurosurgical team. I would add neuro-ophthalmology team as well, immediately after the diagnosis is confirmed. We monitor closely the patient if there is severely reduced visual acuity or severe or persisting or deteriorating visual fields or deteriorating level of consciousness. If it is this the case, we go for surgery. If no, we continue monitoring, close monitoring, neurological, visual, endocrine. If the patient is stable or improving, we continue with a conservative management. If this is not the case, we have to ask for surgical help. And of course, the story of apoplexy doesn't finish there. We have to repeat the assessment of the pituitary function at 6 weeks. And after that, the patients require regular follow-up, and they require regular follow-up to optimize the hormonal replacement and monitor it, obviously, to detect potential hyperfunctionality of the adenoma. We do have cases which present with apoplexy. Hormonal assessment does not suggest that we are dealing with a functioning tumor, and then later, weeks or months, we pick up hyperfunctioning tumor. Regular follow-up is also needed because we need to monitor for tumor progression or regrowth, as we showed with the data earlier on, and neuro-ophthalmology monitoring is needed, but it will be individualized depending as to whether our patient has remained with neuro-ophthalmology deficits. So in conclusion, pituitary apoplexy is a medical emergency. We have to have a high index of suspicion so that we have a prompt diagnosis and prompt effective management. Unfortunately, there is lack of high quality evidence on the optimal management strategy, and therefore we need a practical multidisciplinary approach. The vision and the level of consciousness need close monitoring, and these are the primary criteria for a decision making on what management route we will follow. Predictors of the visual outcomes and the extent of the visual compromise that will dictate surgical intervention, I think they still need to be elucidated. And long-term monitoring, hormonal, tumoral, and if relevant visual are mandatory for these patients. And with this, I would like to thank you for your attention, and I would be very happy to take questions, or please feel free to email me in the email shown below to continue the discussion. Many thanks again.